Uh, Hi everyone. At the outset, I would like to thank Dr. Vasudha and the entire team of Rainbow Hospitals Bangalore for giving me this opportunity. It's been a fantastic and a beautiful session since morning, and there are elite speakers covering such important practical topics so far. And I would at best be moderating this session because I cannot consider myself as a chairperson for somebody like Dr. Girish talking on this topic. Dr. Girish is my senior colleague and a close friend, and he doesn't need introduction to this group of audience. He's a senior consultant pediatric oncologist from Tata Memorial Hospital, Mumbai, and he has done extensive work in childhood cancers and especially solid tumors and neuroblastoma. And he's been one of the big experts in most of the national and international neuroblastoma collaborative groups. He has various publications as he is a teacher of teachers. And he's going to talk on this interesting topic. We all know neuroblastoma is so perplexing, and even today, sometimes it is so fascinating and motivating when you have extremely good outcome neuroblastomas or self-limiting or diseases which get better so fast. And then you have those ugly ones who don't do well in spite of all our multidisciplinary effort. So he's going to talk in the next 20 minutes on improving the outcomes for childhood neuroblastoma for the good, bad, and ugly. Over to you, Dr. Girish.
Yeah, Intezar, can you hear me now?
We can hear you now, sir.
Okay.
Yes, yes, we can hear you clear.
Yeah, I'll just go on full screen. Great. So thank you, Intezar, for this for the generous introduction. I'm not sure whether I deserve that, but I would like to first of all thank Vasudha and the team from Rainbow Children's Hospital, Bangalore, and also congratulate Rainbow Children's for actually opening their cancer center just very recently. I think dedicated cancer units are the need of the hour, especially in childhood cancer. And as we go through this presentation, it only just will exemplify why that is so important. So I was going to talk about neuroblastoma today and for improving outcomes for the good, the bad, and the ugly. So I don't know whether we should call it the good, the bad, and ugly. Definitely there is very good, good, and probably not so good and neuroblastomas in the present day. For 10 years, 15 years back, probably that's what we would look at it that way. But now I think we can look at it a bit more differently. So as you all know, just to put things in context, the neuroblastoma can occur anywhere from the head to the pelvis. It occurs from the sympathetic ganglion, and it's an embryonal tumor which arises from there. The commonest site is the abdomen, and in infants, we tend to see a lot of thoracic neuroblastomas as well. It is a great mimic, and the neuroblastoma can present in various ways. It can just be due to a mass presenting at the particular site and give all the symptoms related to compression around the site. It can present as metastatic disease, which can vary from bony pains to fever to having weight loss and other systemic symptoms. And very commonly, it does present with various paraneoplastic syndromes, and hence neuroblastoma comes through various specialists. It does not necessarily have to come through a surgeon or a pediatrician all the time. It may come through a neurologist, for example, or a gastroenterologist, for example, where presenting with chronic diarrhea with severe malnutrition or opsoclonus, myoclonus, or Horner syndromes may be the presenting features. It is, any system can be involved. It can mimic a benign condition to a completely exorbitant malignant condition. And it is a very protean manifestation. Then sometimes fever can be the only presentation, and it may take weeks for us to actually make a diagnosis of a neuroblastoma. So the challenging thing about neuroblastoma is it has got an unparalleled spectrum of clinical behavior. So most cancers, you have low risks, low stage disease going on to high stage disease. And then the symptoms and the prognosis very much reflecting the progression of the disease from one to other. Neuroblastoma is not that at all. At one end of the spectrum, you have disease which spontaneously can regress. And at the other end of the spectrum, you have disease which is totally disseminated right from day one. It is response to therapy, but very quickly becomes resistant to therapy and relapses quickly in spite of a very intensive multimodality therapy. So a whole spectrum of disease of low risk disease, which actually does very well with excellent outcome. And at the other end of the spectrum is the high risk disease, which is the biggest challenge what we face nowadays. And in between is the intermediate risk disease, which is very much like a low risk disease itself, but warrants some therapy most of the time. And the treatment, what we tailor is completely to what we expect the clinical behavior of the tumor. And we tailor the treatment to the expected behavior based on various factors what we take. So this is overall giving you a general overview of treatment, standard treatment protocols followed in India. Pretty much the same globally as well. So you would divide neuroblastoma into low risk, intermediate risk, and high risk group. And low risk group, you would only observe and only treat in some specific situations, especially if there are life-threatening symptoms, or if there are some age groups like less than 3 months of age, etc., or some other parameters which you would consider to treat. The high-risk disease involves multimodality treatment, and there are 5 arms of treatment, and we will come to that in due course of time. The intermediate risk gets 2 to 4 cycles of chemotherapy and surgery, and many times may end up needing additional 2 to 4 cycles of chemotherapy as well. So this is in overall the schema of how we treat neuroblastoma. And this is pretty much done by all pediatric oncologists in the country, except for the bit about immunotherapy, which we will come to later, and is a rapidly emerging therapeutic option in India now. So conventionally, this is the risk stratification. What we do, you require just the age, the stage of the disease, and the endemic status. And this risk stratification has stood the test of time. And even today, if you can actually just use these 3 parameters, assess the stage accurately, do an endemic test, and put age into the algorithm, you will be able to appropriately or accurately risk stratify more than 90% of the neuroblastoma. So this, if you don't have anything else more fancy than that, that's fine. But these 3 parameters you should be able to do, and you should not treat a neuroblastoma without taking these 3 factors into account. So that is the first step which is there. And that risk stratification is pretty much good across the world in more than 90% of the situations. And these are the outcomes based on those conventional imaging. This is the COG outcomes. The low risk disease and intermediate risk disease pretty much overlap together, and they become almost 90% survival. So there is no point trying to call them as low and intermediate risk disease. And nowadays people call them, a lot of them call them as neuroblastoma with good biology. So the top 2 curves are the neuroblastoma with good biology. And the lower one is the high risk disease, which in 2013, when this was published, had a 40%, 45% outcome. And these were the tumors with the poor biology. So it clearly defines as 2 diseases, rather a good biology disease and a poor biology disease. And these are outcomes in India. This is the recent paper published from PJMR by Deepak Bansal and group. And they followed the treatment algorithm, which we discussed, including doing autologous bone marrow transplant. And they had an outcome of about 40%, which is very, very good, considering that this has been what has been published in the US as well with this strategy. We have not done the high risk peer-reviewed publication yet, but on the intermediate risk, we had an event-free survival of about 75 to 80%, and the overall survival at 90% plus. So these are the data which has come out using just the conventional risk stratification. But then there is a whole amount of research done on the genomics of neuroblastoma because it's such an interesting disease. And numerous chromosomal and genetic abnormalities have been identified. And essentially they get grouped into 2 types. One is those who have segmental chromosomal aberrations, which are the aggressive neuroblastomas. And the other ones, we do not have any segmental aberrations, but have whole chromosome gains, which actually are the good biology neuroblastomas. So the ones which are established are the Mibg amplification and the 11q aberrations. And in the whole chromosome gains, which has been established, is actually the ploidy analysis, where hyperdiploid tends to do much better. So based on these aspects, taking into account the histology as well, and the Mibg status and the 11q aberration and ploidy, a new risk stratification got proposed, which actually gave much more importance to the histological assessment of the tumor, as well as brought in ploidy and 11q aberration. And this was published in 2009, and presently most trials which are undergoing have incorporated these classification into their trials, and we still need to see the validity of this risk stratification to be done in a very big way, because right now This is what was proposed, and this is yet to be validated that this is the best way to take neuroblastoma treatment forward. But then how much does it matter? The segmental chromosomal anomalies and ploidy. So the histological category we can do, it is easily doable in India, and it is something which we should do. Now, how much does 11q aberration and ploidy matter? And they generally matter in very few situations. So one of them is, if you go lower down in the last row, you will see that in MS, which is the stage 4S tumors, you actually, if you have, it would normally be classified as a good biology tumor, and you just observe them. But however, if they have 11q aberration, then it becomes a very high risk. Now, you must understand how this was arrived at. This was done on a bootstrap analysis on about 8,000 children who were paid data, which was maintained in the US. And actually the number of children who actually had 11q aberration in MS is extremely small. So I don't think we should really panic if that is not there. But yes, if it is available, that is one test which would actually change from observation in a child to a completely treating as high-risk disease. But again, that would be in a very small subset of patients. The other one which would actually make an impact of having 11q aberration is only to grade a patient from to a low to an intermediate risk disease. And that would happen if you had in a less than 18-year-old, which was unresectable disease. If the child had no symptoms of any pressure, you would actually watch the child. But again, in that situation, if you have done a biopsy and you can find the 11q aberration is present, then you would actually treat them with some chemotherapy and surgery. And similarly, the ploidy is useful only in a stage M disease, which we normally consider as intermediate risk disease in India. If you do a ploidy and it is hyperdiploid, then you could actually watch them rather than do it. And again, it's an extremely small group of patients where that would be useful. So what I would like to say is that it is not difficult, or is not a big loss if you do not have your segmental chromosomal analysis to actually treat neuroblastoma in India as of today. So, but at the same time, things we have to move forward to. So there have been many other papers, numerous papers, which have looked at segmental chromosomal analysis. And if you look at it as a univariate analysis, most of the time you will find that segmental chromosomal analysis actually makes an impact. That the more number of segmental chromosomal analysis you have, then you tend to have a higher chance of relapse. Some of them affect the event-free survival, and a few of them affect the overall survival. This was a very good study done on a large number of resected neuroblastomas, which did not receive any adjuvant treatment. That means they were all classified as low-risk disease, not received any adjuvant treatment, both from US and Europe. And the tissue were clubbed together on whom it was possible to do the analysis. And in this study, what they actually looked at was a typical segmental chromosomal analysis, which was 1p and 11q, which were established risk factors in neuroblastoma. Now, if you look at the left four graphs, these are in children less than 18 months of age, and the right one are more than 18 months of age. And in the less than 18 months of age, you will see that 1p had only an impact on the event-free survival, but no impact at all on the overall survival. And 11q did not have an impact neither in the event-free survival or overall survival. So what does it mean? That if you have a completely resected less than 18-month neuroblastoma, which is not Mibg amplified and not metastatic, then the role of segmental chromosomal analysis is virtually nil. And we really may not need to do that at all. But if you look at the more than 18 months of age, then the 1p again has no significant impact in the top two graphs on the right side. That's the event-free and the overall survival. But the 11q abnormality has a significant impact if you do not do adjuvant treatment. So if you have completely resected neuroblastoma in more than 18 months of age, which you would normally observe, if you can do the 11q abnormality in those you find it positive, then it is better to give 4 to 8 cycles of chemotherapy in that situation. Similarly, when they looked at segmental chromosomal analysis in unresected neuroblastoma, in less than 18 months of age, now this paper looked at the number of segmental chromosomal analysis other than 1p and 11q. They also looked at the number. And if it is an infant less than 18 months of age, whether you had one or more than one segmental chromosomal analysis, it made no impact at all. But in more than 18 months of age, that segmental chromosomal anomalies incidence not only increases, but you had more than two segmental chromosomal analysis, then the event-free survival as well as the overall survival was a bit less. Now, commonly what we do if you have a more than 18-month-old child with unfavorable histology, we tend to treat as intermediate risk, give 4 to 8 cycles of chemotherapy. Now, in that situation, if you find multiple segmental or more than segmental chromosomal anomalies which are present, then they tend to have a higher chance of relapse. And also, even though they relapse, they are still very much salvageable with salvage treatment. So what does it mean? If you have an unfavorable histology more than 18 months and say less than 5 years of age, you would actually treat them as intermediate risk disease when they're unresectable. You would give about 4 cycles of chemotherapy and resect them. But this is one situation where you may want to consider that the relapse rate may be higher if you have multiple segmental chromosomal anomalies, and actually you may want to consider giving 8 cycles of chemotherapy. So essentially, the segmental chromosomal anomalies have only got a role in 2 situations. So to conclude with what is the risk stratification we should do today, one is that we include the age, INRG stage, and Mibg status, which should be mandatory in all patients with neuroblastoma. We must focus on the histology and tell the pathologist to commit whether it's a ganglioneuroma, ganglion neuroblastoma, differentiating, non-differentiating type of neuroblastoma, and comment on the favorable or unfavorable histology, because that is critical for us to actually take a call without no further genetic analysis to be done. And what is desirable is to do segmental chromosomal anomalies in only certain situations. Maybe greater than 18 months of age, localized neuroblastoma, which is Mibg negative, it is good to do segmental chromosomal analysis. If you have 11q abnormality, you know that you have to give adjuvant treatment, which most people in India do anyway when it's fully excised. If it is unresected and you have more than 2, maybe you would want to give 8 cycles of chemotherapy instead of 4 cycles of chemotherapy. And the 4S is an extremely rare phenomenon, as I explained. So let's move on to high-risk neuroblastoma on the next slides. And then, as you all know, we give induction chemotherapy, we do surgical excision of the primary, we do high-dose chemo with autologous bone marrow transplant, radiotherapy, and we give 13-cis-retinoic acid. And now presently, people are also considering doing anti-GD2 antibody in some patients in India. And we all know this landmark trial, which was published by Kate Mehta in 1999. She randomized 2 randomizations between giving myeloablative chemotherapy versus chemotherapy alone, and then 13-cis-retinoic acid versus no retinoic acid. And this was subsequent publication done 10 years down the line to show what are the long-term outcome of these patients. And clearly the paper showed that autologous bone marrow transplant and 13-cis-retinoic acid had a 5-year overall survival of 59-60%. And the rest options had a much lower outcome. Now, those of you who have been following the literature on this paper may have realized that there was an error in the paper in 2014, and that was picked up by the funding agencies. And subsequently, when the correction was done, it was found that there is actually no significant impact, or not a statistically significant impact on the overall survival, but it continued to have a significant impact on the event-free survival. So after that, there was a Cochrane review done, and the Cochrane review showed, which included Dr. Kate Mehta's paper, clearly showed that there's statistically significant difference in EFS in favor of myeloablative therapy. However, there was no significant difference in the overall survival detected. Now, it is a matter of debate what should be the right parameter to use here, and whether actually high-dose chemotherapy and stem cell transplant actually makes an impact or not, taking into account that there was actually a statistical analysis error in this paper, which was then corrected in 2014. Event-free survival, yes, it prevents relapse, but then if the overall survival is not having an impact, then it is very questionable whether that therapy should be considered as a standard of care. However, to put it in an Indian context, where anti-GD2 therapy is not available routinely, and many of our induction treatment, what we use is not so strong, I do still think that we must continue to recommend high-dose chemotherapy with ABMT on all the patients with high-risk neuroblastoma. So then there was also, as part of the anti-GD2 antibody randomized trial took place, another landmark paper which was published by Alice Yu. And this actually took into patients who are actually with retinoic acid and plus or minus immunotherapy in the last bit of treatment. And the results of this, all of you know, is very well published. And this made a very significant impact of about 20% improvement in event-free survival and about 10% improvement in overall survival. And then subsequently also, although the difference did get narrowed down, it still continued to make significance. So since transplant had shown some impact, so the question arose whether actually doing 2 transplants would actually improve the outcome. And there was a randomized trial done, and the randomized trial used the US arm of treatment, which also included using carboplatin etoposide melphalan as the main transplant myeloablative conditioning. and the thiotrypanocyclophosphamide was for the first transplant in the to a tandem transplant arm. So, however, the study had a competing trials going on. There was already the anti-GD2 trial going on. So there were patients with anti-GD2 who some of them who got anti-GD2 and did not get the anti-GD2 who got entered into the trial. And also in US, children who were more than 3 years of age, who were NMIC not amplified, stage 3 more than 18 months of age, were considered high-risk neuroblastoma them, and a lot of them got included in the single transplant arm. And those are generally expected to do better. So the results of this trial cannot be completely accepted, nor it can be completely rejected. The patients who came were not really uniform. So if you look at outcomes of all patients, yes, you do see that the event-free survival was better. But as was the case in the Kate Mathias paper, in the first one, the overall survival did not make an impact by using 2 transplants instead of 1. But however, if you look at only the patients who received anti-GD2 therapy through Alice use trial and who also had undergone tandem transplant, there was clearly a benefit. So tandem transplant was seen to have an impact on those patients who subsequently went on to have an anti-GD2 therapy. Otherwise, on its own, without the anti-GD2 therapy, the tandem transplant did not seem to have so much of an impact. But as I met, there were patients with competing trials who got onto it, and that's why this data may not be as clean as we would have liked it to be. So at the same time, the myeloablative conditioning used was carboplatin, etoposide, and melphalan. And then from the European study, they had done a randomized trial between busulfan, melphalan, and the CEM. And they published that the busulfan melphalan is a much better arm. And maybe that is one of the reasons why this transplant may not have actually worked that well. So MSKCC never actually believed the transplant works from late 90s or early 2000 itself, and they felt that they had limited value, and they had a very strong induction regimen which was given, and they actually did not do transplant in a substantial number of patients, but they went into immunotherapy quite early. And they published the data where they showed that patients who actually did not have transplant and went on to receive immunotherapy actually did as good as patients who actually had bone marrow transplant as well. So on that basis, there was a huge lobby which actually did not think that bone marrow transplant on its own had a huge impact on neuroblastoma survival. So last bit is on Mibg therapy. This is another question which is asked routinely for many of us, whether what is the role of Mibg therapy in today's age. So we actually do not know how good it would work in a high-risk neuroblastoma setting. This was the pilot study which was done by the COG, where they actually gave the induction chemotherapy, Mibg, followed by 1 stem cell rescue, then went on to do the myeloablative chemotherapy with stem cell rescue again, and followed by rest of treatment. And this pilot study is completed and published, and it shows that it is feasible, doable, and does have anti-neuroblastoma effect. However, the study was only a pilot which was done, and it was mainly to look at feasibility and toxicity. And there are some toxicity, but nevertheless, it is fit enough to take to a large trial. And this is the ongoing study presently, where they're looking at both Mibg therapy as one of the arms, and also looking at different conditioning regimens for transplant, which also includes Boomel in one of the arms with Mibg. The other one includes thiopycyclo and CEM, and also looking at crizotinib, which is also shown some benefit, although very modest in ALK-positive neuroblastomas. So I think I will end here by telling what are the strategies to improve outcome. And especially in our country, I think the most critical thing is to involve a multidisciplinary treatment very early in the treatment of high-risk neuroblastoma. Risk stratification needs to be very accurate and very appropriate. And the pathology assessment is mandatory. We should just not put it as neuroblastoma. And many times we see that it was a ganglioneuroma, or sometimes an intermixed ganglioneuroblastoma, which does not warrant any chemotherapy at all. In the low risk, if you classify a patient as low risk, observe, but keep them on very active surveillance, because that giving chemotherapy clearly avoids toxicity. And surgery has limited value in a low risk to do. I mean, there's no benefit of resecting the tumor in an infant when the child is asymptomatic. And even after giving chemotherapy to a low risk disease, the symptoms have gone away. And if it's not going to be resectable, there is absolutely no benefit of going and trying to do heroic surgery. Intermediate risk disease chemotherapy can be decreased to 4, as in some of the favorable histology, and the rest where you have 11q abnormality, you can continue to give 8 cycles of chemotherapy. Segmental chromosomal anomalies, as we mentioned, has proved to be useful only in limited situations. But before you embark onto a segmental chromosomal anomalies, please do an Mibg status, and if that is amplified, then the rest of it is really immaterial. Surgical approach, which we didn't discuss, is very critical. That's one of the issues we find amongst various hospitals in India. If it is a low and intermediate risk disease and you decide to do surgery, taking out 50% of the tumor is adequate. Anything more than 50% is good enough. If you are having a high risk disease, however, you must go for a near total or a gross total resection. That means more than 90% of the tumor should be resected and does warrant aggressive surgery if you want to actually improve the outcome, which sometimes involves even vascular surgery, etc. But that needs to be done in a high risk. But in a low and intermediate risk, please do not use that approach. Even getting more than 50% of the tumor is good enough. And if it is less than 50%, then there's no need to actually do any surgery at all. And in high-risk neuroblastoma, the timing of multimodality therapy is very critical. There is a fixed time at which you should actually take the patient for surgery, a fixed time for transplant, and a fixed time for you to actually do radiation and further immunotherapy or differentiation therapy. Delays in this only has been demonstrated to lead to higher resistance development and for the child to relapse much earlier. So many times, that's why it's very critical that we actually get the multidisciplinary team involved right in the beginning. It may not be within your own hospital. You may have to involve different hospitals, but it's necessary to work on that. So just to give you an example, we ourselves cannot do neuroblastoma transplants in our hospital because of the large waiting list. But we liaise with multiple hospitals in Mumbai, especially with CTC Borivali, and we have done more than 60 autologous bone marrow transplants in the last 2.5 years in them, but we just liaise right from the beginning so the dates are fixed. So it's critical for us to actually work together to actually deliver the best care so that we can get 40 to 50% outcomes in what just the way the PGI has shown as well. We should continue to do a single ABMT for high-risk neuroblastoma, and that should be the standard of care because our induction, which is rapid Kojak, which is what most of us use, is not as strong as the Sloan-Kettering induction or as strong as the COG induction for us to offset the advantage of ABMT. So if you're using rapid Kojak, then ABMT is definitely mandatory. There is, however, no role clearly established for tandem ABMT, and that is not something which we should recommend. The last, but definitely not the least anymore, is actually the role of immunotherapy anti-GD2. And as you all must have heard, that there are now at least a dozen patients in India who have received the anti-GD2 therapy. Some of it given on compassionate grounds, or rather one or two given on compassionate grounds, and majority of them has been paid by the family. And after significant amount of negotiations, it is still continues to be expensive, but at least affordable to a proportion of patients. And I think as a pediatric oncology community, we need to get together and actually galvanize support more for actually bringing the price down of the anti-GD2, because that is the only way, what I see is the robust way forward for high-risk neuroblastoma in the present setting, rather than trying to do autologous BMT or tandem BMT, or even considering Mibg therapy, which has not been very proven yet. It's also possible that this Sloan-Kettering antibody, which is also coming to the market now through Viamax, may also come into the market, or may also start being available in India. Nevertheless, it's something which we need to work on, and hopefully there'll be some company which will make a biosimilar and get approval, and then the cost of it should be much less than. I think I will stop here and take any questions. I just given you a bird's eye view of the challenges what we face in neuroblastoma and some of the things how we can actually go forward.
Thanks, Dr. Girish. That was a fantastic talk.